Investigations for anorectal anomalies and imperforate anus. First of all, plain X-ray of the pelvis in lateral view. In lateral view, either invertogram with the baby is inverted, the head down and the leg below, the head here and the leg here, the leg above and the head below, invertogram. And it is possible to use this position, which is called the cross table lateral view. After 24 hours, the baby during 24 hours swallow air. The infant is held upside down. Therefore, it's called invertogram. And a coin is fixed at the anal dimple to mark the normal site of the anus. Then take lateral view. Draw the pubococcygeal line. Pubococcygeal line from the inferior border of the symphysis pubis to the coccyx. This is the pubococcygeal line. Or this is inferior surface of pubic bone and coccyx, pubococcygeal line. If air inside the rectum, this is air inside the rectum, and above that line, it is high anomaly. Here, this is the line. And here, air is below the pubococcygeal line. Why this is below? This towards the lower limb, below. We speak anatomy. This is the pubococcygeal line. And the air towards the lower limb is below this line. Therefore, this is low anomaly. This is the pubococcygeal line. And this is the air in the rectum. Above the pubococcygeal line. Why above? Because here is the head and neck above. And this is the lower limb below. Therefore, this air anatomically above the pubococcygeal line and this high anomaly. In addition to plain X-ray, which will show the dilated loops of intestine. It is very important also to measure the bowel skin distance, which is the distance between the coin on the skin and the bowel, air at the end of the bowel. This is called the bowel skin distance. If this distance below 15 millimeter, it is low anomaly. If more than 15 millimeter, it is high anomaly. Sure, this distance less than 15 millimeter, therefore it is low anomaly, while sure this distance more than 15 millimeter, this is high anomaly. In addition to X-ray and the coin test, pelvic and perineal ultrasound, CT scan, and the MRI will show the definite pelvic anatomy and the exact vertebral anomalies if present. Urine analysis and IVU very important to discover associated fistula or urinary tract anomaly. Never forget investigations all over the body to detect associated congenital anomalies. What is the treatment of anorectal malformation? First of all, resuscitation, then surgery. What is the aim of surgery? First of all, relieve intestinal obstruction if present. Closure of any fistula. Place the rectal pouch into the perineum in the normal position of the anus. And finally, preservation of anal sphincters and sphincteric physiology to keep competence of feces. What is the method of surgery? Method of surgery is variable according low imperforate anus or high imperforate anus. In low imperforate anus, reconstruction without any colostomy, just local perineal operation. Immediate local perineal operation without any colostomy with very good prognosis in low imperforate anus. During operation, we use muscle stimulator to localize the exact site of the anal sphincter. Then the anal opening is mobilized and transferred to the normal position. In case of ectopic position of the anal opening, example, in this case, this is ectopic position of anal opening. Therefore, mobilization of this anal opening to the normal correct anal position. And after healing, never forget the anal opening should be dilated daily for 3 to 5 months to avoid subsequent stricture formation. This is a simple operation in low anomaly. Detect the exact site of anal sphincter by muscle stimulator. The anal opening should be mobilized to the normal site of anus, and the condition followed by The operation followed by dilatation for 3 to 5 months to avoid stretch. If anomaly, high anomaly like this, this is high anomaly. The traditional operation is 3-stage repair. 3 stages repair consists of, first of all, temporary proximal colostomy. The colon is opened on the surface of the body to divert feces. Temporary colostomy. After 3 to 6 weeks or 4 to 6 weeks, we perform operation called posterior sagittal anorectoplasty. Why it is called posterior sagittal? Because the operation begin by median sagittal incision from the sacrum to the anal dimple. Median sagittal incision from sacrum to anal dimple. Therefore, it's called posterior sagittal. Followed by closure of any present fistula. Remove any connection with the urinary tract. Then anoplasty. What is anoplasty? Create an anal opening in the correct site. In the correct site, in the center of the anal sphincters, detected by muscle stimulator. We do an anal opening in the correct site. Then dissect the anal pouch. Dissect the anal pouch and pull this rectal pouch through the defect. Therefore, it is called pull-through operation. Putting the rectal pouch in the correct anal opening. Finally, reconstruction of the sphincter complex. This is posterior sagittal anorectoplasty. Incision posterior from the coccyx down to the correct side of the anus. Then divide any fistula. Then anoplasty, creating an opening in the correct side of the anal orifice. Dissect the rectal pouch and pull through the defect to open this rectal pouch in the correct side of the anus. Then reconstruction of the sphincter, and after 2 to 3 months closure of the colostomy. Therefore, first colostomy, then reconstruction. After 2 to 3 months, closure of colostomy. Colostomy after 6 weeks reconstruction, then 2 to 3 months closure of colostomy. The reconstruction is called posterior sagittal anorectoplasty. Recently, nowadays, all this reconstruction is done in one stage. Recently, one stage repair by, as before, posterior sagittal anorectoplasty plus laparoscopic approach. Therefore, combination from above by laparoscopic approach and the perineal approach by incision from the coccyx to the correct site of the anus. This can be done in one stage repair. This is the final repair of the posterior anorectoplasty. Thank you for good listening and good luck.